Hi, this is Raphael at Net Medical, and I'm back with another video today. This one is about understanding test performance. It seems that there's a lot of confusion lately about COVID-19 testing and how to use it, and I thought it was appropriate to make a little video to do a little bit of a deeper dive into the subject. How do we use the tools that we have out there? So let's go into it. Understanding test performance. First thing I want to say is this talk is really about two test types, molecular and antigen tests. There are other types of tests, but for the sake of this talk, I'm talking just about the molecular and the antigen tests because I believe there's a lot of confusion surrounding the use of both of those. The molecular tests amplify the RNA of the virus in order to detect it. They act a lot like a microscope does in magnifying, if you will, what you can see and what you can look at. And the antigen tests, they test directly without amplification, so they're more like a magnifying glass. You get a little better look at what you're trying to look for, but not as good as, say, a microscope. Now, even the gold standard of these tests, these PCR molecular tests, can have false positives and false negatives as well. So, for the heat that the rapid tests are taking right now, don't forget, all tests can have false positive and false negative results because there's no such thing as a perfect test. Let me get to this. This is my visualization tool that I made, and I am going to use a theoretical population of 200 people. I'm going to set the prevalence of the virus, or the prevalence of the disease, if you will, at 50%, so half the people are sick and half the people are well. And in my hypothetical test, I'm going to set the sensitivity to 99% and the specificity to 99%, which, if you're a test developer, I think you would admit is an amazingly good test, because those numbers are pretty hard to hit. What this means is that, out of the sick people, the sensitivity will tell you how many positive samples for virus that the chemistry of the test will detect as positive. In this case, it sees 99 true positives and 1 false positive. In other words, since there is no such thing as a perfect test, there's some condition that a person can have that will cause the test to produce a positive when it really wasn't positive. And then the specificity is the same idea. It's how many known negative samples that the chemical process of the test will detect as negatives. And in this case, specificity of 99% gets you 99 true negatives and 1 false negative. Now, I need to emphasize that these values reflect the performance of the chemical processes that are involved. And I think some virologists they know where I'm going to go with this, right? Is that these are independent of how an immune system reacted to the chemical sample that we're testing. In other words, the chemical sensitivity and specificity of a test has nothing to do with the symptomatic or asymptomatic status of a patient. And I know there's a lot of really smart people that are getting stuck on this, right? It just doesn't. They measure chemical performance of a test. It is a chemical measure of what's going on. So we know how this test acts when we know how many sick people and how many well people there are. But when we test random populations, we're actually doing the opposite of what we just talked about with sensitivity and specificity. And thanks to super smart people that made Bayes' theorem and understand statistics and all this stuff, we have this idea of positive predictive value and negative predictive value, and we can answer questions about statistical things that we don't really know, but we know enough stuff around it to calculate what the answer should be. And in this case, the prevalence is going to play in big. But you don't need to understand any of the math. You can just watch what I'm going to do here with the prevalence to understand why we're going to see false positives and false negatives, okay? I'm going to grab the prevalence slider, and I'm going to make everybody in this population sick. Every single person out of the 200 people, 200 of them are sick. That means that we should expect that any test, if it was perfect, would give us 200 sick people as a result, right? But here, if we got 10 negatives from that test, then we would have to expect that all 10 are false negatives. because we know everybody's sick. So the 10 negatives that it did cough up, those are false negatives. Now let me do the other way. Now I'm going to grab the prevalence, I'm going to slam it all the way to the other side. Okay, in this case, the prevalence of the population is in the population is 0. So we have 200 well people, and all our little people down here turn beige. And we know that if we got 10 positives, that we should expect that all 10 of the positives that we got are false positives, because we know that everybody's well. And that's really the core of the issue here, right? Let me slide that back to 50%, which is the case that everyone intuitively understands. Oh, 99 and 1, 99% sensitive. We know what that is. And this time, instead of slamming it to one side or the other, I'm going to slowly creep it down. And I want you to watch what happens when we get to 16 or so percent. Boom. There's our first false positive. We got 10 positives in this test, and as the prevalence in the population was dropping, we were testing random people, and now one of these positives is a false positive. And that's just because we're testing more well people. The more well people we test, the more we're going to find the failure condition of that test. And as Timothy Stencil at the FDA said a couple weeks ago on the town hall, this is a completely expected result. Let me keep shrinking this slider, and you can watch what happens. As the prevalence drops, we get 5% prevalence. We now have 2 false positives. And then as we approach the limit of the sensitivity at 1%, now if we got 10 positives, we should expect that out of those 10 positives, that 5 are false positives. Let me reset it one more time. I'll put it back in the middle, and I'll plug in some numbers that are familiar to you if you've been dealing with testing in any capacity. I'll put in a sensitivity of 98.1 and a specificity of 97.3, and then I'm going to do the same thing and shrink the prevalence down to roughly 3%. This time at 30%, we begin to see our first false positive, and then as we shrink it down, it grows and grows and grows to the point that we're matching, say, the 3%. Here, we're seeing out of 10 positives that we got, that 5 of them are false positives. So that's how prevalence plays into testing random populations. And that gives you, hopefully, gives you some instincts, right, about what to expect with false positives and false negatives. Now, another area where people are getting stuck is this idea that the gold standard PCR can invalidate the results of an antigen test if the two conflict, right? Is it like, is an antigen test result that conflicts with a PCR test a false result? Well, not when you're talking about positive predictive value and negative predictive value. That's actually something different. But it's important to understand that they aren't measuring the same thing, right? And let me give you some examples of how to think about that. The gold standard test, these PCR tests, can pick up viral fragments that the immune system has already run its course over. And those fragments aren't contagious because the virus has to be in the shape of a virus. It has to have the spike proteins, it has to have the lipid bilayer, it's got to have the RNA inside wrapped by the nucleocapsid. Like, it has to have the structure of a virus if it's going to go do damage to somebody else. But the PCR test, it doesn't really have a way to tell you whether or not it was good. I mean, it kind of does, in that it gives you a CT value, right, which gives you viral load, and if your viral load is high, then you know that that virus is probably nice and healthy, right? But the dead virus in a person, right, is likely dangerous for immune dysfunction reasons, and for the diagnosis of a patient, you want to use these PCR tests to tell what you want to do next. But if we're starting to talk about viral load, and I think you can kind of see where I'm headed with this, that if you have a positive antigen test that doesn't amplify, it's likely that your viral load is high enough to be contagious. So when we use this test, what are we really trying to diagnose? Are we trying to diagnose the health of the patient or the quote-unquote health of the virus, right? And I think we have a test for each one of those. And I think that the viral load is going to start playing a really important role in how we understand what's going to happen with these tests. Because with a false positive rate of 50% down here, there's some challenges, right? You got some real challenges. So let's talk about the virology that surrounds this. The virology of SARS-CoV-2 indicates that the viral peak happens days before symptom onset. And that's a real problem. The viral load, this virus is so efficient at replicating that it blows through the system as fast as it can before you even start to see symptoms. And it does it in a way where just breathing can transmit the virus to another person. And that's what we're seeing in this asymptomatic spread. So if your goal is to prevent outbreaks, then what you should be measuring is the strength of the virus, because you're most contagious around that viral peak when that virus is at its strongest. But to detect peaks, you're going to need a test which quickly tells you how high the viral load is. And that test is an antigen test. And because of the prevalence in the population, you're going to see false positives. But you're also going to hopefully catch all the people you need to catch, all the people that are contagious, right? You can apply different methods and say that you can do 2 antigen tests spaced, say, 24 hours apart. And that'll give you even a higher resolution read of the viral curve of the person that you detected. So take 2 tests. If one of them's positive, then that person needs to follow up with diagnosis. And if you're diagnosing the patient, because of the situation where you have immune dysfunction and immune dysregulation, a molecular test is the test you want to use there. And hopefully you get one with a CT value that can give you an indication of the viral load of that patient, which the viral load is still pretty high, even when the symptoms start to show up. So we have these 2 tools in the toolbox, and I think we can design protocols, if you will, to work with the tools that we have and design regimens that will allow us to do better testing, to not only diagnose patients and how to treat them, but to measure the health of the virus, if you will, and where is it, to detect it so that we can prevent the outbreaks. The last thing I want to say on this whole thing, because I know I'm running a little long here, is that if you don't completely understand the instructions inside of the test that came with the test, then everything about your testing regimen is going to be compromised. And that's going to be a matter of training and following procedures, right? I can think of 100 ways to get all false negatives out of a test without, if I don't have to follow the instruction. So get to know your test really well. Train your people really well. If your test has a mode that waits for you to do the reading versus a mode that does it immediately, understand the difference ahead of time. Even so much so to talk to people that you know they're using it. Understand what they've learned about it. Completely read the instruction for use. Completely read the quick start guides. Watch all the videos on all of the manufacturer's sites. You want to know everything you can about these tests in order for the stuff that we're talking about here to matter. For your sensitivity and specificity to matter and your protocols to matter, you're going to have to absolutely understand how to use these tests. And look for further guidance, right? Look for people that are finding better ways to use it. One good example is in the University of California, they do a lot of testing on asymptomatic patients, and they published a document showing how to do edge-to-edge guidance on the Binax Now test in particular to know whether something was truly positive or truly negative. And that's the kind of knowledge that we out in the public here can be sharing with each other, and we can be building on each other's strengths in order to get better control over this pandemic. Well, thanks for joining me. I know that was a long one, but I appreciate it, and I'll talk to you soon.